Perfect. Thank you. Okay, now we are recording. Excellent. So we're going to talk about the first steps of pediatric airway management and the important things to do early to try to improve the airway, because, well, many people think the airway is best with endotracheal intubation. That is the final step. And the things that you can do to rescue, to save somebody's life, are the first steps that we're going to focus on today, especially bag mask ventilation, which is the key skill that I would want all of you to be able to perform as part of your duties. We have some equipment. It's not a lot. There are many more of you than there are the equipment, but everybody we will give a chance to do with the mannequin to practice the bag mask ventilation, the Goodell airway, the supraglottic airway, and if you want to, the little mannequin, you can do an intubation. These mannequins are easier to do everything than a human, except for the supraglottic airway, just because they have no secretions, no saliva, so everything is very sticky. But otherwise, yeah, you can practice all the other steps and become more comfortable, hopefully, with the, it's not so much the equipment as it is how you position the patient, how you hold your hands, and that you observe that you are improving the ventilation. So let's start by talking about the pediatric airway. And I'm going to start with the anatomy. And hopefully these slides will cooperate to go to the next one. There, good. All right, so I have put up here a profile of an adult and an infant airway. And of course, the child would be somewhere in between these. And I would ask you, what are some things about the infant airway that are special that we need to think about when we're managing a child who needs resuscitation? Anybody? What do you see here that is special that you would think about? More narrow, definitely. So their sizes of equipment are multiple, and you must choose, but be prepared. You might need something bigger or something smaller than you predict. What else? Okay, excellent. So you're talking about the sort of position of where the glottis and epiglottis are, right? So the adult has a neck, and they have an elongated trachea with the glottis being right about here. It is below where the junction of the chin and the neck are. So the glottis is down here. Whereas in the infant, the glottis is very close to the junction of the neck and the chin, very high, superior, because their neck has not elongated as happens during puberty. And the epiglottis, therefore, is extremely high. In fact, some children, you can have them open their mouth and you can see the epiglottis in the back of the throat, which tells you you do not have to go very far to encounter the airway when you're managing. What else? Excellent. Excellent. So it may, it actually may not itself be bigger, but it takes up more of the space than you would see in the adult, where you have additional room. And that means that it's more prone to obstruction, particularly if there's any infection or trauma, or even if the child just is unconscious and lying back, that tongue can be a very important source of obstruction. Okay, and then lastly, the shape of the head. Okay. Remember, the brain reaches its full size at about 2 years of age. And therefore, that head has to be big enough to accommodate the growing brain. And I'll show you a couple of pictures that illustrate that even better. So the size of the occiput is important for positioning. Small passages, both in the nose, which becomes extra important because of the big tongue, and in proportion to the size of the mouth. And then, as someone mentioned, that glottis, which is superior and anterior compared to the adult airway. Another difference that's a little harder to see in the picture like that is the shape of the airway. And the adult airway is pretty much a cylinder. It is uniform, and the glottis is the narrowest part. So once you get past the glottis with a tube, you actually have to blow up a balloon below the glottis, or all of the air will start to leak. Whereas with the pediatric patient, the glottis is here, but below the glottis in the subglottic area, you're going to have narrowing at the level of the cricoid cartilage, which is the only continuous ring around the airway. What that means is that you may be able to pass a tube through the cords, but then encounter resistance here, particularly if there is any swelling or trauma to that airway. And that can make a very big difference in how much the child is working to breathe before you are helping to manage the airway, and is one of the reasons that they develop respiratory failure much earlier in their course if they have upper airway obstruction. A baby with lower airway disease, bronchiolitis or something like this, they can breathe very fast for a very long time. But a baby with upper airway obstruction, it is a tremendous amount of work if you get high airway resistance. And the reason is this: if you have a typical infant airway, which has a diameter of about 4 millimeters, and you put just 1 millimeter of edema around that airway, you have reduced the diameter by 50%. But because resistance in the airway is inversely proportional to the 4th power of the radius, you've actually increased the resistance by 16 times with just 1 millimeter of edema around the inside of that airway. And that is going to create tremendous work for the child with upper airway obstruction. And that's why we may have to intervene, whereas an adult who gets 1 millimeter of edema around the airway, yes, it's going to reduce the total size, but it only increases the resistance 3 times. And we are able to, we may have a sore throat, we may cough, we may feel bad, but we're not having to work so hard to move air through such a tiny little aperture. So the first step in airway management that is key is positioning. And the best way to see the position of the airway is to look from the side. So this is my first recommendation, is if you're evaluating the airway and whether or not the child is in the right position, look from the side. And this shows you what happens because of this big occiput. If the child is laying supine and is not conscious, their head is going to flex and they're going to have a tongue that may obstruct the airway in the back. And so the simplest thing to do is start with positioning. And the position is one where you put the ear and the shoulder at about the same level with a roll behind the shoulder. And this all by itself improves the airway. If the child's really unconscious, you also need to use your hands to lift the jaw or lift the chin, because it will pull the tongue up away from the back of the throat in that case. But just by doing this, you may substantially improve the airway using the shoulder roll. So here's a real child. Look at the size of that occiput. The big brain. Child is going to be very smart. Okay, he's going to go to university. He's going to do very well because they have a very big brain. But this is what the body does to allow for that brain to grow. when one is a young infant and young child. And you can see that if you have them laying on something here, that the neck is in flexion and the axes of the mouth, the throat, and the larynx are not quite lined up. You have to make a turn around a corner in order to have an open airway. Whereas if you put a shoulder roll, you get better alignment of these axes. Still not perfect though, because what you want is for the child to be in what we call the sniffing position. And the sniffing position is two parts. Okay? One part is some extension of the neck. The other part is moving the head forward. And that's the part we tend to forget. Okay? We are good at putting the shoulder roll to extend the neck a little bit, but ideally you actually want both of these things so that you can push the head forward without causing it to flex. So extend and then push the whole head forward. And that's the step where you actually make your airway the most aligned. Let me show you a better picture. Okay. So here's the baby who has a shoulder roll so that they can extend the neck, but they've also elevated the head to push it forward. And now you can see the line is much straighter and it will be easier to pass a tube into that airway. We're not overextended. The nose and the eyes are looking right up at the ceiling. If we pull the neck back, we simply move the airway further out of alignment. So neutral. And again, the ear and the shoulder are right at about the same level. So you look from the side at this patient and you can see that the airway is positioned in the best way that it could be. Now, as the child grows, the body grows to catch up with the head. And as that happens, you have a different situation. Okay. No longer do we need the shoulder roll because we have a head that is of normal size, but we still need to push the head up. And this is probably the most common problem that I see with an airway in a child, is that people remember the baby and they will, oops, there we go. They'll put a shoulder roll underneath the child, but they won't put the head elevator. Okay. So in this case, what we want to do is again have the nose and eyes pointing straight up to the ceiling in a straight line here. Okay. And we still have the ear and the shoulder that are at the same level, but we've done it by putting something behind the head and pushing it forward. Make sense? Okay. All right. So starting with just positioning, you can make a big difference in the quality of the airway. Again, if they're truly unconscious, they've had a long seizure, and you give them 3 doses of lorazepam and they're unconscious, you still need to lift the chin and the jaw, but this positions them in the best way possible. Now, remember we talked about the tongue, and in addition to using the airway maneuver, one of the things that can make a big difference is the Goodell airway. Okay, so this will only be tolerated if the patient is truly unconscious without a gag reflex. Okay? And you can test that. If the patient reacts when you insert it, the patient is hopefully able to maintain their airway. But if you have someone who's very unconscious, you can use this to try to create a passageway between the tongue and the back of the throat. Okay? And so really you're just trying to hold these 2 areas apart to improve the airway. The size is important. You typically measure from the corner of the mouth to the angle of the jaw. something that is too big, the problem is that it may push down on the epiglottis and block the airway. So if you put an airway, a Goodell in and things get worse, take it out. Take it out and just go back to your manual hand maneuvers. If it is too small, it may cause the tongue to be trapped by the airway and actually cause more obstruction than help. So again, if you put the airway in and things seem worse, take it out and start again just with your regular maneuvers. Okay. This is the most important skill that you can learn to manage an airway. Position the patient correctly. Ensure that you've got a good grasp on the airway to open it and to be able to move the chest. The reason this requires some practice is that you're going to do 3 jobs with 2 hands. What are the 3 jobs that you need to do in order to ventilate this child with a bag and mask? You need an airway maneuver to pull the jaw up. Good. You need to make a seal, and then you need to squeeze the bag, right? So that just takes some practice to be comfortable with one hand doing both the seal and the airway maneuver. And you can see from this illustration, this is one way of accomplishing that with just one hand, using your fingers to create a C around the mask so as to make a seal on the face. And then using the fingers, in the case of a baby, maybe just one finger. In the case of an older child, several fingers, maybe in the, looks sort of like the letter E, to lift the jaw up into the mask. Okay? So we're not pushing the mask down onto the face, we're lifting the jaw up into the mask and making a seal. So you need to, please. Which one? The neonate. So the neonate has a shoulder roll and has the great big occiput. Okay. So at the moment, this looks like it is working okay. But I understand what you're saying because the baby's a little bit extended, isn't it? Ideally, I agree with you. It would be nice to push the head forward a little bit. That would be perfect in order to line everything up. We can't see what they're doing here for positioning or what exactly they're doing here for positioning, but this size child needs something behind the head to push them forward to be in the sniffing position. So we will practice this on our small mannequin here so that you can work on making a seal, opening the airway, and squeezing the bag. Now, there are some children who either because of a problem with the face, the bones, the structures, or trauma, who it is very challenging to do 3 things with 2 hands. And if that's the case, you call a friend and you can have now 4 hands to do 3 jobs. And that makes things easier. And that is having one person make the seal and do the airway maneuver, and a second person to squeeze the bag. Okay. This is one example. I think you have to be, you perhaps are better covering that mask with more of your thumb because air could leak out the top or the bottom. This is the way I prefer to do it, is with a C on either side of the mask, and then fingers to pull the jaw up into the mask and create your seal. This gives you a lot of control. And now this person can squeeze the bag and you're just focusing on making a seal and opening the airway. Okay. So proper positioning with our rolls, and then proper mask position with a good, with a good seal and a good airway maneuver. And if I were taking care of this child, what would we do? We want a headrest to push that forward to more optimally open the airway. Very good. Oopsie. Now, if you've done that and you've added a Goodell airway and you're still not able to ventilate, you're still not able to move the chest, you can think about a supraglottic airway. So the supraglottic airways are placed blindly. So you do not need any type of laryngoscope. And they are very good when they are positioned correctly. Just like the Goodell airway, if they're not positioned properly, they can make things worse. So if you insert one of these devices and the patient is worse in terms of ventilation, that's the time to take it out and go back to what you were doing with just the bag and mask. These are designed so that the tip will essentially lodge in the esophagus. And then the opening that is forward will allow the air being ventilated from here to be directed right at the laryngeal opening, reflecting the fact that the esophagus is lower and backwards. The airway is superior and anterior. There's a couple of different styles. The one we will use today is the iGel. In the all but the very smallest iGel, there is a port which allows air to escape back up from the esophagus. So there's a lumen here at the tip that allows you to either insert a catheter or just allow passive air drainage. And in some of these, you actually have a channel that you can use to apply some suction in the other devices. This is the one that it was sort of the classic laryngeal mask. This was the first one that was created, where you have to put some air in once it's in place to make a seal around the larynx. But before you put it in, you oftentimes will take the air back out because it will be easier to pass. We'll practice this on the mannequin. Again, it's a little hard because the mannequin is plastic and the device is got a soft rubbery tip and it's very sticky. But don't be frustrated. Just look at it as an opportunity to actually handle one of those devices. They now make some of these supraglottic airways so that you can take off this top piece and you can actually insert a tracheal tube that gets pointed right toward the airway. Obviously, the balloon is down when you are passing this, but you can insert this and direct it right into the airway. And then this comes off and this comes off so that you can pull the laryngeal mask out over the tube, which stays in place. We don't have one of these here to show, but this is how someone may be able, if you can get the laryngeal mask sitting just right, then someone who knows this technique can hopefully do an intubation through the mask without having to take it out. It's also a blind technique, although you can put a bronchoscope through here and look out the end with the scope to see if you are in the right direction. So again, it's and then put the tube over the bronchoscope. Exactly. So yes, there are a couple of different ways you can do this, but this is an advanced technique that we're not going to talk about today. But this has to be seated in the proper place over the glottic opening. If not, if it's a little to the side or if it's too deep, it will just fold over the epiglottis and cause obstruction. All right. So how many people have heard someone say that child has a difficult airway? They've used that term. That child has a difficult airway. What do they usually mean when they say that child has a difficult airway? What are they usually referring to? Difficult intubation is typically what people are talking about. And if I hear that a child has a difficult intubation, I say, okay, we'll get all of the experts here and we'll get the fancy equipment and the extra things that we might need. But I am not as worried about a difficult intubation as I am about a difficult mask airway. A true difficult airway to me is a difficult mask ventilation, because then you have nothing to offer until the patient is intubated. Maybe you can offer a supraglottic device. If you can't do mask ventilation or supraglottic device, then you truly have nothing to offer short of intubation. Those are the worst airways. And I'm going to show you some examples of those airways where your approach needs to be very thoughtful and careful. Most of the airways that we approach, there's no reason to think that they're difficult. If from the side, again, look from the side, structures look normal, you can open the mouth and you can move the neck, it's probably going to be okay. You can probably mask ventilate that patient and rescue them while you call for help and get other people available to help with these devices. So if someone says to me, that child has a difficult airway, I say, what is difficult about it? Why? And they say, oh, it's very hard to see. We need a fiber optic intubation. I said, but what about a mask airway? And they say, oh, yes, I feel better. If you can use a mask and move the chest, that's your job in the early part of resuscitation. So it's really about your hands. This is actually a description for anesthesiologists about what to do if you thought the airway was going to be okay, and all of a sudden it's not okay, an unexpected difficult airway. And these first three dots are the ones that apply to our stage of the resuscitation early on. If you aren't already using 100% oxygen, use 100% oxygen. That one seems pretty obvious. Call for help. If you cannot mask ventilate a patient who needs to be mask ventilated, that's a crisis. That's an emergency. Call for help, and it will take some time for help to arrive. So if you're unable to mask ventilate, look at the position of the patient. And then step number one is to get a friend to come and help do a two-handed seal and maneuver. Insert your Goodell airway, or in some cases, if there's a problem with the mouth, potentially a nasal airway. If you still can't ventilate, think about a supraglottic airway. And those are the key steps. Those are the first things that hopefully you can establish some oxygenation, some ventilation. It may not be perfect, but you are keeping the patient alive until additional help can arrive. Okay? And there's many more steps for the anesthesiologist who may take care of this patient involving all sorts of different equipment. But really, the basic things are the ones you want to troubleshoot to see if you can make the situation better, so that there is time for someone to offer these other maneuvers. All right. So what we're going to do is we're going to look at some pictures of difficult airways. And I want you to tell me what it is you expect to be the problem and how you might work to make the airway better if you were in charge. Okay. Again, picture the scenario where the child has a long seizure. You give several doses of lorazepam to help, and now the child is unconscious. How are we going to maintain the airway and support the airway? Okay, so let's start with this patient on the left. What are you worried about? Okay, excellent. So this one's obvious because he's clearly, the tongue is so big it's sort of protruding from his mouth. And I would expect, if he is unconscious, And particularly if he's lying on his back, he's going to have obstruction. And so I'm going to do the first steps, position him properly. I'm going to do an airway maneuver to try to lift the tongue away from the back of the throat. What might be helpful? The Goodell airway might be helpful in this case. And then use the bag and mask, and you might need two people. You might need an extra person to help make a good seal and do an airway maneuver. I think that this is a disease like Hunter's or Hurler's syndrome, mucopolysaccharidosis, where you have deposition of the polysaccharides in the soft tissues, including the tongue, but it adds an extra degree of difficulty. Okay. What about this individual? Yeah. Yes, very good. So very short neck, no neck, no neck. Okay. And I'm going to predict that what is there of the neck is not flexible. Okay. It's probably pretty fixed. And so she's sort of stuck in this position of flexion. And so if she has a long seizure and gets a lot of benzodiazepine and is now asleep, what are we going to do? Okay, try to position as best you can is the first step. Okay, but the problem is she may not have the ability to extend. So two-person mask is probably going to be needed in order to make a seal and move the chest. She may do better with a Goodell airway. She may do better with a supraglottic airway because everything is kind of fixed. You can't move it around as much. And so she may be a very good candidate for the supraglottic airway if we're not able to ventilate just with a bag and mask. I think this is something like either Klippelfeil or a dwarfism of some sort where everything is small and fused. Yes, we should definitely do a jaw maneuver. Yes, absolutely. I'm just not sure how much we're going to be able to do because of how rigid everything is in this area. All right. Okay. So let's appreciate how looking from the side really shows you more information than looking directly. And what do you see here? No chin. We had no neck, now we have no chin. So this is a child with a very small chin, micrognathia, also retrognathia, probably Pierre-Robin sequence of some type, often comes with a cleft palate as well, big overbite. And why is this going to be a challenge for you? Yeah, the tongue is going to be causing obstruction when the child's not conscious, and there's just not much jaw to pull away. So what might be helpful here? Okay. Say again. Good positioning, absolutely. And probably the Goodell airway is going to be important because there's no space between the tongue and the back of the throat for this child. Now, if there is also a cleft palate, it may be harder to position the Goodell airway because it may want to kind of fall into the cleft palate, in which case a supraglottic airway might really be the best intervention because it will bypass that cleft area and allow you to deliver. But I would try to position and try to mask ventilate and try a Goodell airway in those steps. But this is a child who is probably not someone who can be intubated in the routine way. We must call for help for this one and try to maintain some oxygenation and ventilation in the meantime. All right. How about this young boy? So now we're looking straight on. but I can tell you that if we were looking from the side, he would probably look a little bit like this. He's got a very small chin and probably not much jaw. In fact, I think the jaw on this side is not complete because his face looks uneven. Any idea what this is? Then say again. Treacher Collins. Yes. So this is Treacher Collins. And so oftentimes there are ear malformations as well as jaw malformations. Okay. Again, we're going to start with the basics position. We're going to try to do good mask ventilation. You might need 2 people. He would likely benefit from a Goodell airway, but he's probably very difficult to intubate. So that's not our destination. We're going to call for help. All right. Very happy baby. Doesn't look like the baby has a problem, but if this baby has a long seizure and now is unconscious, we have to help. What's going to be the challenge here? Yeah, the cleft is going to be a problem. Why? Why does the cleft make it difficult? Putting the mask on and making a seal. All right, because here you have to be able to seal this very wide space. And so the usual type of mask for a baby with a big cleft, you just have a lot of trouble doing that basic maneuver with your hand and the seal. You may need to use, in fact, an adult size mask and put it over the entire face, including the eyes. And with that, be able to actually mask ventilate, because the child or infant masks are simply not going to cover this entire area. Now, beyond that, this is wide open. Okay. Beyond that, as long as this baby is not also Pierre Robin, it is just a cleft, there's lots of room and obstruction is not going to be a problem. So you're going to use perhaps a different kind of mask. The problem with the Goodell and the supraglottic for this is that they tend to get hung up here in the cleft. And so the best maneuver may just be to position and use a big mask to ventilate with 2 people providing the seal. Maybe supraglottic, if the supraglottic can be positioned properly, it could be helpful. Sometimes the cleft makes it hard to get into the right position because it can displace. And it's certainly worth trying. It just may not be able to sit in the right place to use. All right, let's get a couple of more. All right, baby on the left. Again, the profile tells it all. What are we missing? I think we're missing a chin. And so, this junction of the chin and the neck is virtually, it's like a smooth line. Okay. So there's, virtually no jaw here to pull up on. This is another example of Pierre Robin. I know this is a little hard to see in this light, but what you're seeing here is a huge tongue. Okay. A tongue that not only is protruding, but looks very edematous and engorged, and so is unlikely to even tolerate a Goodell or a supraglottic airway. What are we going to do for this patient? What are you saying? Go ahead. Okay. Nasal, there you go. All right, we still have some access to the airway here. This may be the one time that a nasal airway is actually the most helpful to create a space at the back between the back of the tongue and the throat. Nasal airways in general are not all that helpful, but this may be one time. And I might even use a small endotracheal tube as my nasal airway, because the nasal airways are so floppy that it just may not be enough to hold a space. you can use a small endotracheal tube into the nose positioned at the back just to create a passage and deliver some oxygen. Okay. All right. Yeah, so this is one of the craniosynostoses. It's either Cruzon or Apert syndrome. And you can see a couple of features like the proptosis, which is going to, we want to make sure we don't injure the eyes. But look what happens when we actually look at this patient in profile and how you can see more about the airway. Okay. So these patients have mid-face hypoplasia. So everything is very close together here. There's the bridge of the nose is right in between the eyes. So there's no bridge of the nose below the eyes for you to make a seal with. So what is it that's going to be difficult about managing this airway? The bag mask is going to be a real challenge because there's the face is so flat that there's not very much to make a seal with on either side. And again, it's going to be hard to get something that's going to seal the nose. This is, again, someone who might need an adult face mask in order to ventilate and use 2 people. These children are typically not difficult to intubate. It's before that, that's the problem. It's doing the mask ventilation that is a challenge because of the abnormalities of the face. And so our job is to get through that phase. You might be able to use a Goodell to make things a little bit better, or a supraglottic airway. But just the early steps are going to be the most challenging. Okay. So massive hydrocephalus, but an infant body. Okay. How are we going to position this baby? Excellent. We're going to have to build not just a shoulder roll, but a body roll. And so we're going to have to use multiple things to build up and take up the space. And then I would still put a little something behind the head to move it forward. So again, positioning is going to be absolutely key for this baby. It's you just need one that's the right size for the whole patient. It's a very tiny little face. So I would just, as long as you have an infant mask, you should be okay because the jaw looks normal. It's the position that is going to be the challenge. Yep, you might need 2 hands. I think you would have to try and see if you can make a seal and do an airway maneuver once you had the baby positioned properly. Now here's the opposite problem. This is a craniosynostosis of a different type than what we showed before. This baby has a very flat occiput. Okay, and that's because the brain is going this way instead of this. Okay, so when we position this baby, what are we going to do? So yeah, you may need, if you use a shoulder roll, you may put this baby too far in extension. Okay, so we're going to have to look from the side to see what happens with a shoulder roll, which we would typically use at this age. And we may need something to take the place of the occiput to push the baby's head forward when they're lying flat. I don't know what this person's diagnosis is. I think it's probably a congenital syndrome like Goldenhar syndrome, hemifacial microsomia maybe. And I say that because there are ear abnormalities. But this could be someone who had trauma to the jaw or cancer of the jaw and had something resected. Either way, there's literally no chin. And this is someone who is going to be very challenging to mask ventilate if they're unconscious. This is one we need help. We're probably not even going to be able to get the mouth open enough to insert the supraglottic airway, which just truly may not fit in the small amount of space there is. between the chin and the airway structures. So this is a patient who I would be very worried about and call for help early on, because the basic maneuvers are probably not going to help her much. Now, that's a very cute little baby. And, from all little babies have sort of like the little dimple chin and everything. But again, if you look from the side, you get a much better sense of what that airway is going to be like. Right. So these nice big cheeks are nice because they give you something to make a seal with, but there's not much chin to lift. And this is going to be a baby that's hard to mask ventilate. That's where your other things like your Goodell airway and maybe a supraglottic airway will be helpful. The fact that the baby has a feeding tube, probably means that they have trouble breathing and eating at the same time, which just goes along with the fact that the airway structures inside the mouth are very small. So I would try your usual steps, but recognize an adjunct like a Goodell might be really helpful. All right, one more. Okay. This is a lymphatic malformation, maybe a cystic hygroma, I'm not sure. Okay. But the anesthesiologist is nervous because what part of the airway is most involved in this? Is it up here at the mouth? No, it's down here at the larynx, which might be either compressed or deviated because of the mass. And, in fact, up here, things are probably not so abnormal, but how am I going to make a seal and do an airway maneuver with this patient? Because the jaw is involved in the lesion. So you're probably going to want two people to help make a good seal. You can try on this side of the airway to do a little bit of a lift. But this is someone who may be very challenging to mask ventilate and for whom a supraglottic airway may make a big difference because it's so hard to make a seal on their face. And then it's the anesthesiologist who has the hard job. They're going to use something special like a fiber optic scope in order to do that. All right, questions about the initial approach to the airway? Positioning, okay. Mask seal, two people if you need it. Airway maneuver, Goodell airway. Think about the supraglottic airway. Has to be positioned just right. And anticipate, call for help if you see one of these patients who may have a challenging airway. Make sense? Okay. Questions? All right. Yeah, if it's not seated just right, if it's too deep or it's off to one side or the other, you're not going to get effective ventilation. It needs to be right in the midline and seated just at the proper place. And this is where if you put it in and things are worse, meaning it may not be seated exactly right, just take it out and go back to your basic maneuvers. Yeah. Yeah. So it's easy to put in, right? Because it's blind. You just put it in. But hitting the exact right place where then you can ventilate easily, it's not so, it doesn't happen just like that. You may have to adjust it. You may have to make sure that the head is perfectly straight. If the head goes off to the side, the laryngeal mask will slip off the place where it's supposed to be. So keep the head perfectly straight as you're doing it. Make sure it's right in the middle protruding, when we have endotracheal tubes, we frequently move them over to the corner of the mouth. This needs to stay right in the middle so that it is not turning one way or another. And look for chest rise, look for end tidal CO2 to make sure you truly are ventilating. What you don't want to do is insert it and assume that it's working for you without actually seeing that you're getting good chest rise. Yeah, you can try it again, try to seat it again. I think it depends on the situation. If the baby's, in arrest, I would not take very long. I would just go back to bag mask ventilation. If this isn't working, it's making your airway not work for you and the patient's not getting oxygen. Okay. Yes. Oh, good question. I would say probably bigger is usually less of a problem than something too small. But this is why you need to have all the different sizes available, because what you estimate may not be what the child needs. Yeah. You already know that you figured out what it worked? It's a good question. If I had someone who I was worried might have progressive swelling of the airway, for instance, like anaphylaxis, where I see the tongue is getting a little big, the lips are getting a little big, I might think let me get this in place while I can and not lose the window of opportunity, or smoke inhalation, something like that. Otherwise, I tend to go in a progression. Yeah. If you call for help and you can get someone who could intubate right away, even better. Right? But they're going to need you to support the airway and make sure there's some oxygenation in the meantime. All right, very good. Let's we're going to do some work with our mannequin friends here. And I again know that there are many more of you than there are of the mannequins, and so I will make sure everybody gets a turn. But if you are waiting, you don't have to, you don't have to sit here and watch everybody go through this, but just make sure that you come through so that you have the opportunity to try it. I want to show you a couple of things about the bag and mask. So this is a bag valve mask. And what is the valve for? What does the valve do? So you're correct. Part of the valve is the pump up. So some bags come equipped with the top off valve. In this case, it pops off at 40 centimeters of water when it is activated. Okay. If it's open, if it is now, and I want to give her a pressure that is beyond 40 centimeters, it's a release valve that pops off there. If I close it, now I can generate as much pressure as I want. Now, when might you need to use this with the valve closed? Maybe in an arrest. Why would it be a problem though? Why wouldn't you be able to use a normal pressure? Yeah, there you go. It's probably not to overcome the chest compressions. You should be able to, if the airway is open and the lungs are normal, but there could be something that caused the arrest. So severe asthma, for instance, with very high airway resistance, or a drowning where the lungs are very, very stiff. You may, when you first start ventilating, you may need to generate pressures that are higher and therefore use the pop-off valve. I think most of the time we think of the pop-off valve as a good thing, so that we're not, there's some obstruction, we're not causing excess pressure in the airway. The goal is to move the chest. So the other purpose of the valve is to concentrate oxygen in here. And so it is literally a one-way valve. It only opens when you squeeze the bag. So can I use this device for a patient who's breathing by themselves? Can I use this device just to give extra oxygen? No. Okay, very good to know. If I do that, the patient is rebreathing in the mask because the valve is a little bit like a fish mouth that only opens when I squeeze. Okay, so the patient who's trying to draw a breath in from this isn't going to get air. It's intended to only open when I squeeze the bag. So this is a good device for someone who is needing assisted ventilations.
Patient is breath make, so yes,
Yeah.
kind of.
So you're doing
sometimes breathing, yeah.
You need to then also assist their own breaths if you want them to be getting oxygen. So you watch and try to time with their breath. So in other words, if they're breathing 5 times a minute, and you know it really should be more like 20 times a minute, you're gonna give breaths in between, but you're also gonna supplement their own breaths.
Is it really too much and you push oxygen
No,
out of the.
well, you're right. I mean, I could provide some flow of oxygen. But yeah, no, I would not, I wouldn't lift the mask. I would literally just watch for the child to make the respiratory effort and provide some extra support.
Okay. So you have to, it's really
To assist it. Exactly. Give them a little extra. And flow inflating bag, which people may use in the newborn resuscitation or may use in the operating room. This can give a continuous flow of oxygen. Even if the patient is breathing on their own, you can use this to, there's no blockage to the oxygen flowing through this. So you can use it for a patient who's breathing, or a patient who's not breathing, or a patient who's breathing a little. And that's why people like to use these in a resuscitation. It also has a pop-off valve here. It doesn't really look the same as the other, but there's a little ball in there that's the pop-off valve. I can't show you how this works because unless you have gas flow, this doesn't work. Okay, and that's why when we're in an acute resuscitation, we often reach for this because we don't need gas right away. Of course, we're going to add oxygen to it to help with the resuscitation. But I can use this anytime, anywhere. I can only use this if I've got oxygen flowing. Once I do have oxygen flowing though, this dial changes the amount of flow that gets down to the patient, then will determine how much inflation of the bag and how much pressure it can generate. So this takes a little bit of practice to use, and that's again why our first step when we are rescuing is to reach for weapons. Does that make sense? Super glide airways. This is the broken. This is a classic one. You can see it's got a pump that's going to be inflated again. And sometimes someone asks what can we do to make it better, the amount of inflation of the pump.
may matter in terms of how well it is seated. So a little bit of less, a little bit more, to make it seal, you can't see it, but you can hear if there's a leak and see if it makes the chest rise better if you put a little more air in this. The Vidal, this is the smallest one we have. This does not have any channel to allow air to escape, unlike the bigger ones. Have an opening down the tip that at least allows air to passively come out from the stomach. And if you have a catheter that's small enough, you can actually put it in and have it protrude beyond the end of the Vidal. These are only intended to sit over the larynx, which, if you remember from the picture, is not very far into the neck. Okay, this baby's larynx is probably right about there. So you're only going to expect this to sit about like that. And that much is going to be protruding from the mouth. And that's normal. That's expected. But again, try to keep it right in the midline to the extent that you can. This baby is very frustrating to use this airway because it gets sticky. And we'll try to use a little bit of water to make it better. This baby, though, is very easy to ventilate into. Too easy. Easier than it would be on a human. And if you look at how this baby's positioned, got a shoulder roll built in for you. Right? And what do? They locked off the back of the occiput. So they've also got a bit of thrust. So that's why, again, mouth is open, everything is intact, but you will see how little you have to insert a blade in order to visualize the airway. All right, now, I need a volunteer. You can help me with this baby. Any volunteers, please? So this baby is have a long seizure and multiple doses of lorazepam and is currently obstructed and breathing only a few times a minute. Let's start with just positioning.
Okay, so we put the rib on the side and then consider the shoulder roll.
Good, and this is all laid out, so they may make the shoulder roll on it. Right, it's a good question. Something that doesn't belong. And, yep, please.
Yes, we need to do on the shoulder and then also and then this.
Yeah, we don't have anything at the great side, but that's
Okay, then we have the eyes and if it's horizontal.
excellent.
Yes.
Very nice.
And then we go with that. And it's like that. I know it's right down.
It's off, so you can see it.
That's right.
A little more. This baby, I happen to know, really doesn't like any neck extension. Let's make your roll a bit less so that truly it's neutral.
Okay.
Okay, there we go. So you just make that small adjustment so that you see the chest rise. Very nice. Thank you.
So it's the first thing that we have to think about if we see the chest is not really. Maybe that someone else now does what we ventilate.
Yeah. Yeah. Little more relaxed of the roll. But in particular, you know, overextending is gonna obstruct, it's like flexion, is gonna obstruct. This baby, unfortunately, has a plug in the mouth, so there's, you can't do anything else other than just bag mass belly with this baby. This baby, you can do all of the things, you can use the bagging mask, the mask is a little big. If you don't do that, and you can do the oropharyngeal airways and the Goodell airways, so we're gonna give everyone a chance to do that. Let me see if I just put a little water on this Goodell, if it will go better. When you're gonna put in, the supraglottic airway, the key is you want it to go behind the tongue. And if the baby's unconscious, that tongue may be falling back. So you can either use a tongue compressor or in a bigger child, use your thumb, and sort of pull up on the jaw. Make sure that it goes behind the tongue. That there's the water. And you insert it just a little. Because that means you've got the tip wedged in the esophagus, and if you keep pushing, the risk is it's gonna do this and potentially obstruct the airway. So now let's see if I get inflation. I'm keeping it right in the midline. Not the best, but not the worst. And so if this makes